the Buddhist metaphor of like the thought would be the first arrow that is shot at you, and then all the rest of the pain is coming from the 2nd through 100th arrows, which is, in this example, the mom going throughout the rest of her day, and then when she's holding her baby, scanning her body of like, do I want to throw this baby? Is that thought going to come back? How to be patient. Welcome back, guys, to How to Be Patient, the show. No, I'm not going to make an OCD joke. Preston, how are you doing today?
I'm back, and I'm welcome.
You're back. You're here.
I'm good. It's like my first week back, I guess second week back, like really getting into the swing of things. So we're filming this in January 2026, and my birthday is in 2 days. So that's exciting.
Your birthday's in 2 days. How old will you be?
I'll be 29. The big 29,
Diva.
Yeah, I mean, at this point, I'm just celebrating
20s.
every day. I'm past the 27 club, Like, sorry, Jimi Hendrix, but I'm leaving you behind.
I never even thought of that. But then after you get to be 30, flirty, and thriving.
Yeah, it's an in-between age, I guess. So I can be 30 and flirty, yeah. What about you? How are you doing?
I am good. I have really been liking consult psychiatry and peds. And it's busy, but it's like so fun. Fun's the wrong word. It's like so interesting because the complexity of the patients is so high. And in peds, one of the like hard things, but also like things that make you think really deeply is that because of good ethics, there's a paucity of evidence for approaches. So like in the adult literature for like catatonia, right?
Yeah.
There is pretty clear guidance. In peds, we are kind of trying to work from the adult literature, but it's like, is this the same thing as in like a 7-year-old? I don't know. Like the whole reason you would get catatonia in a 7-year-old is so different, and like the developmental component is so interesting. So anyway, not to nerd out on that, but like I've really liked it, and I liked CL in adult, and so I kind of forgot that I liked CL and then got to it, and I was like, this is fun, and it's fun to talk to the pediatricians and collaborate.
That is really interesting, that the uncharted territory of, I guess, child psychiatry in general. And we make so many assumptions about kids just being little adults, I think.
We don't do that. We don't make those assumptions.
Sorry, Margaret doesn't. I think like there can be, I guess, like general medical assumptions sometimes when you're applying things like psychiatry and neurology specifically. But like you're not myelinated in the same way, yet and your brain's dysfunctioning differently, at least from like a biological level. I'm like, we make these mistakes, and Margaret's like, we do not.
Well, that was like a knee-jerk reaction, because in peds they like beat that out of you metaphorically when they're like literally. I remember my first lecture at WashU for med school in peds, and it was like, what are kids not? Little adults. It was like, my friend who's a pediatrician, we like make a joke, and I'm like, well, you know what they say, adults are just big kids, so I'm applying these things.
Yeah, everyone's a peds patient at the end of the day.
At the end of the day.
It makes me think of those medieval painters that never learned how to draw a child's proportion. You ever like look at the 1300 papers? Oh yeah, it'll be like baby Jesus in like Mary's lap, but it's just like a full-grown man.
You're like, hey.
because the monk who drew that has like never seen a child.
I'm not going to talk about there's a reason it's painted like that, but that's all I'll say. Speaking of things that happen in childhood, OCD happens in childhood.
Oh.
So that was my not smooth segue. But this episode is highly requested, multiple seasons in a row for us to do an OCD episode, multiple OCD episodes. And I just have happened to been interested and experienced personally when I was a kid, OCD, and then worked in an OCD residential out here in Boston. And so today, listeners, we are doing the OCD episode. Preston, how do you feel about OCD?
Oh, I like it just as much as every other disorder. I actually, if you're ADHD or anxiety listening, I love all the disorders equally. I don't have favorites.
What's your experience working with like populations with OCD, generalized like clinical sentiment? Is there any like challenges or interesting things that you think about when you think about treating people with OCD from your experience thus far?
Yeah. So I guess There's a couple things I've noticed about OCD. And one thing that's been like compelling to me actually is to think about it like along the spectrum of all anxiety disorders, I guess. So, and I kind of explain that to some of my patients that maybe have like some OCD traits without necessarily going into like OCD disorder. And they're like, well, how can I have all these anxiety traits? But then I have like the occasional intrusive thought, but like a lot of my behaviors aren't around these intrusive thoughts. So like I put them, organize them on a continuum. That's been helpful to me. One thing I've found with OCD patients that gets missed a lot, and especially like when I had less experience, is really inquiring about the intrusive thoughts. I think a lot of people, when they picture OCD in the media, their mind goes to the compulsions, but the compulsions being those like kind of ritualistic behaviors that you see where
Yes,
people are like washing
observable.
their hands a ton, or they're like, I have to, count something 7 times, or I have to like straighten all these things. Like that's what they picture. But that's driven by this like obsession or intrusive thought, which can be hard to ask about. And that's been kind of challenging for me to ask about. I usually
Mm.
generally just ask about unwanted thoughts that they experience and then just kind of try to follow the conversation there. So I guess those are like kind of the general sentiments I have about it.
Mhm.
I think it's been interesting diagnosing it. Treating it has been very difficult. And I honestly have been treating it somewhat with pharmacology and haven't had a chance or really tried to treat it from the perspective of a psychotherapist.
Mhm.
And I think I would be a little intimidated by that challenge, but I think it'd be good
What do
for
you think
me.
has made it challenging about, like, treating like, so far, what's been, I guess, challenging to treat or, like, has made it hard for you as a person acting more in the prescribing role?
Um, I guess because people don't respond to medicines as easily as they would to something like anxiety. So you end up having to crank up to higher doses, which also exposes people to more side effects. So,
Mhm.
for example, like paroxetine can be pretty effective for OCD. Has a pretty tight binding profile for the SERT receptor, which is possibly why it's more effective for anxiety disorders. But also, paroxetine is pretty anticholinergic, can be pretty sedating. So people may feel like, yeah, like by the time we cranked up the dose to like here, it made my symptoms a little bit better, but now I'm having all these side effects. Darn, it's like it feels a lot more like threading a needle, where you have less leeway than with some of the other disorders I can prescribe for.
Mhm. Yeah. No, I think it's a good point. It's something that we'll get to in treatment, which is that, m generally speaking, people with OCD need the higher end of the range for these medications. And for something like paroxetine, that can especially be a problem. For some of the other more kind of classically prescribed, although paroxetine is FDA approved for OCD, there's less of this issue of there's always gonna be the issue of the side effect burden as you go up, but there's less of it than compared to paroxetine, like, against all other SSRIs. And then the other issue with it that we'll get to is thinking about prescribing and understanding people's responses and understanding the OCD response to being on the lookout for side effects. Whereas maybe someone without OCD might experience, like, very mild, like, upset stomach or nausea 10 minutes after they take the medicine and then kinda just, like, stop noticing it and not fixate on it. Like, there's a question in the prescribing of how OCD might actually impinge or make side effects more noticeable or bothersome,
Mm,
and then prevent you from ever getting to these higher doses that actually are the things that help more often for OCD, which I think is just, like, an interesting, like, this like, the psychodynamic of prescribing is, like, how the illness interacts with it.
yeah, psychodynamic psychopharmacology, I think, is like the fancy term for that. We had a lecture on it the other day, but we didn't talk about OCD, which is really interesting. Yeah, it's like an extra layer. The disorder itself complicates the response to the treatment.
Yeah. Which some might say is every psychiatric illness, but I think with OCD, it can be particularly interesting. So, as our listeners know, this is not up to date, the podcast. And so I'm actually not going to go through like the
That's not up to
DSM
date.
diagnosis.
Up to date, the podcast.
Yeah. I mean, does Up to Date have a podcast?
I don't
Probably.
know.
We have many colleagues in this space. who, if
I
you
would
want,
listen.
and Preston's episodes that are more epidemiologically based, that are much, I will include in the show notes the APA guidelines in terms of the current standard of care for OCD treatment, as well as the child ACAP guidelines. And so if you want a comprehensive document talking about epidemiology, I can also, if you DM me for book chapters, I can give you book chapters. But all of that is to say, I want to make this very clinical and I want to make this very concrete and kind of generate ideas for people who are treating or listening to this and like primary care doctors with OCD or with patients with OCD, et cetera. So the first thing I want to say is outside of anything else, let's start with how do we evaluate for OCD? And we are going to get to that right after our first break. Be right back.
Be right back. If you're anything like me looking for the perfect pairing for your couch, look no further than Cozy Earth's Cuddle Blanket. It is buttery soft, smooth, and just large enough for me and the cats.
And sometimes you're looking for a pairing to really just settle in on your days off onto your couch with that cozy blanket, in which case, Cozy Earth also has very beautiful, very comfy matching set pajamas.
Yeah, and my first pajama set ever. So 2026 is off to a good start. The other thing is that there's a 100-night free sleep trial and a 10-year warranty on all of their pajama sets, blankets, and any other product. It's one thing I really like about the company.
Share a little extra love this February and wrap yourself or someone you care about in comfort that truly feels special. Head to cozyearth.com and use our code PATIENT for 20% off. And if you get a post-purchase survey, be sure to mention that you heard about Cozy Earth right here.
Celebrate everyday love with the comfort that makes the little moments count.
So in 2026, my goal is to open a very small private practice as a post-grad psychiatrist. And one of the tools that is helping me do it is Simple Practice. Preston, have you heard of Simple Practice?
Yeah, I have heard of Simple Practice, actually. I use it as a patient. Well, I guess my therapist technically uses Simple Practice.
And is it in fact simple?
It is very simple. It's convenient. Yeah, would recommend.
Yeah. Well, from the therapist side, Simple Practice is an all-in-one EHR that is HIPAA compliant, high trust certified, and it is built specifically for therapists. So it brings scheduling, billing, insurance, and client communication into one place so that you are not juggling multiple systems just to run your practice, or if you're Preston's therapist, to see him.
I mean, I'm enough to handle as is. She doesn't need to worry about other complicated things.
And if you're just starting out or growing your practice, there's also a credentialing service that takes the headache out of insurance enrollment, which honestly can be a huge lift and something that I was a little scared of.
So if you're ready to start the business side of your practice, now is the perfect time to try Simple Practice. Do it with us. Well, I guess me in the future and Margaret now. So start with a 7-day free trial, then get 50% off your first 3 months. Just go to simplepractice.com to claim the offer. That's simplepractice.com.
Okay, so someone walks into your office. They have been referred from their primary care doctor. They've been kind of anxious, kind of depressed. They didn't respond to 125 of sertraline and started getting really bad nausea whenever they would take it. So they're sending it to you, psychiatry, to figure out what's going on. You do an evaluation. And what are things that you think about when someone's coming in for primarily pretty high anxiety? There's always little maybe depression sprinkled in these referrals. So what is the differential you're kind of thinking through?
Yeah, it's I'm high-end anxious. And then when you kind of ask them about anhedonia, they're like, yeah, I don't want to do anything because I just feel nothing but anxiety all the time. That type of archetype. Okay. So I try to think about obviously the medical stuff first. So if I don't have any of those labs, they're just coming in cold, I'm like, okay, is this person's thyroid out of control? And they're experiencing anxiety from that. The obvious can't misses, come on, man, a little bit of propranolol would have fixed this, or however you would attempt the thyroid workup. And then substances. So if this person's withdrawing from substances or they have some sort of chronic substance use, and then outside of those things, when we started getting into the anxiety disorders, I start to wondering about a couple different things. So first would be obviously generalized anxiety disorder, social anxiety disorder, and then different ineffective coping strategies that can manifest into personality disorders, trauma related disorders, so PTSD or complex PTSD can manifest as a lot of like anxiety disorders on the front end. And then I still actually think about severe mental illness too. I've been burned by this a couple times where I've had patients that are experiencing hypomanic episodes or manic episodes. And the only language they had to describe their manic symptoms was that they're anxious.
Yep.
Like I've had a patient who said, like, oh, I'm so anxious and the anxiety just makes me want to accomplish all of these things. And the anxiety makes me want to stay up and the anxiety makes me want to do that. I'm like, you're describing the symptoms of a manic episode and you're just calling it like, do you feel fear? And he's like, no, I feel great. I just feel anxious. Like I got to do stuff. And I'm like, we're using different language here. I understand now. So like you can't, especially in these like initial evaluations, you can't always like take the language at face value, I guess. And then obviously OCD falls under that spectrum of anxiety disorders.
Yeah. No, I totally agree with you. I think that was a really good differential of all the things that, we are looking for anytime we do a comprehensive eval with as psychiatrists, but especially when it comes this presentation, which is maybe one of the most common presentations that we get, the things we're thinking about and how anxiety, similar to some of the things we've talked about from like a neuropsychological functioning perspective or kind of a neurocircuitry perspective, anxiety or what looks and sounds like anxiety is not like one set of like serotonergic receptors going on and off in some tiny part of your brain. Like anxiety can be manifested from a lot of different sort of quote unquote malfunctions or errors. And so getting clinical and kind of descriptive, which is what we have for diagnosis and treatment right now in psychiatry via the DSM, as well as thinking of like, how does this show up in different ways and what kind of words do people use? Similar to like, if you do the like MDQ, which is like the screen or the like symptom checklist for bipolar disorder, take any of your super anxious patients through that and they're going to start screening a little bit for bipolar and it becomes a more complicated question. So yeah, I think that's a great differential. I think the other thing I think about, which I didn't ask you, is the differential and then the comorbidities or the friends that flock together with anxiety and OCD. So the complicating comorbidity that won't be ruled out in differential, but there is something that in ped psych we can sometimes call our version of the unhappy triad, which is OCD, tics or Tourette's, and ADHD. So thinking about comorbidities as well as your differential, because it's not all Occam's razor.
Sure. It was funny was when you were describing that triad, I was about to say OCD and eating disorders. That's where my mind went. Yeah.
Or like less common, but common in anorexia. Yeah. And trying to think of a couple other things. So yeah, I just think comorbidity, because that can be a huge one. Because there are people, like you can be bipolar with comorbid OCD. So there's our umbrella of like, what's the one thing this could be? And we kind of try and parse that out first. And then we reopen the umbrella and say, and also, is anything complicating the picture of what we expect?
Mm-hmm.
So you walk in, let's presume they have an excellent PCP, as all PCPs are. And I say that as the child of a PCP. They've done the like general like workup for anxiety, like their thyroid's normal, their regular labs we look at are normal, they've been seeing the sun, they have vitamin D, They're eating enough regularly and without difficulties or body image concerns. So we're not worried about an eating disorder right now. One of the things that we would go into next, or that I try to go into, because I think one of the biggest components of OCD over the term of the treatment, diagnosis, evaluation, treatment, is going to be the psychoeducation component of like people often. So the onset of OCD is early, right? It's childhood is when a lot of anxiety disorders come on. So it can be in teenage years, but it can also be like at 6, 7, 8.
Is there, I guess maybe I should know this, but you know how ADHD has like a young, like an age floor that you could diagnose below? Does that apply to OCD as well?
I don't think so. Like I think that I've seen kids that are diagnosed at like 4.
Wow.
Yeah. I mean, and technically ADHD you can diagnose at like age 3 or 2. So maybe, but like that's like kind of the unknown in child psych, where it's like, can a 4-year-old have bipolar? And like some people argue heavily yes, some people argue heavily no. So, but yes, but childhood onset.
So more of a gray area question. Gotcha.
Yeah. And so the reason that I bring up the childhood onset, besides for clinical pictures, is someone has lived with OCD for their whole life, and OCD is relatively pretty genetic. They might have been raised by someone with high anxiety and OCD. And so this like alarm bell has been ringing their entire life. And therefore, they don't hear it in the same way
Like an
anymore.
ICU
Like
nurse with alarm fatigue.
yes.
Yeah, that's how I picture it.
And it's like, you hear, how I can't hear you. What are you talking about? What are you talking about? You hear that? No. Yeah. Yeah. So like in terms of thinking about from like the child perspective, it's like a kid comes up to, let's say a parent and their child both have like pretty severe anxiety. One has GAD and the kid has OCD. The kid starts to experience OCD when they're like 7, 8, let's say. And then when they talk to this parent about it, the parent is also struggles with uncertainty in terms of anxiety functioning. And the way that they cope with that is they respond by trying to force certainty and have a lot of like plans or something. And so then the kid is taught that this is the way you deal with it, which may or may not be a coping mechanism that makes their OCD better, or in this case, worse. So I just say that to say that like throughout the course of working with people with OCD, both in outpatient in my like specialized clinic the last couple of years, in kids and adults, in postpartum, and in the residential setting, one of the biggest things that is the continual work is helping them figure out what's them and what's OCD. Does that make sense?
Yeah. Because OCD has essentially been carving their identity. And a lot of these maybe traits they probably think of as their personality has been them just learning how to cope with this unwarranted distress.
Well, and it's like, listen to your intuition, or listen, like, what does your gut say? And it's like, their gut says something is wrong all the time. So like, how do you know what you believe in or feel if that alarm bell is just always on, right? It's really hard to hear a whisper when the alarm bell is screaming.
What? That was me. That was me trying to hear over the alarm bell.
So in terms of like evaluation of OCD symptoms in particular, how do you ask about? So you mentioned intrusive thoughts.
Mm-hmm.
Maybe we should do this as a role play.
I usually just start with, do you have a history of OCD?
Let's do a role play. Okay. Let's start now. You be the doctor. I'll be the person with OCD. And listeners, I was diagnosed with GAD in childhood, but I'm pretty sure it was OCD. So I'm going to answer not from my own life experience, but from the felt sense of my life experience with really struggling with OCD when I was younger.
Okay, gotcha. Okay.
Hey, doc.
Well, yeah, welcome to the clinic. Have a seat wherever you'd like. Pick whatever chair you want. There's 3 chairs. You can pick whichever one. Okay, so what brings you into psychiatry today?
I'm just worried all the time. And like, I'm getting like so tired from worrying all the time.
So you can't remember a time when you haven't been worried?
I mean, like there are times I'm like having a good time, like at school or with my friends. But like, it just feels like it's like the background noise of my life.
Okay, I see. And this may be about everything, but can you help me understand what this worry is directed towards?
What isn't it directed? I mean, I feel like the biggest thing is like my like sister got in a car accident like a year ago, and I for 6 months like couldn't think about anything besides like her getting in the car accident and if something had happened. And so like whenever I worried about her, I felt like if I didn't text her, then like something was going to happen. And she would get annoyed with me, but she also like knows that's me, so it's fine. But like it was like I couldn't not. Like I felt like she was going to die if I didn't do it.
So during this time, it was all directed on the thought of your sister dying.
Yeah, but it's also been like I like will take a test and I'm so like fixated on it that like I'll like have been doing well in the class and understood it and feel like I did well in the test. But after I leave it, I just am like running over the test over and over. And I like have to check my test like 2 full times in addition to checking it while I go. Because I just feel like I'm like missing something and I'm going to like fail. And I like feel so panicky.
I see.
And it's like it's like the whole like 4 days after. It's not even when I'm taking the test.
Gotcha. So these panicky thoughts, they stick with you and they drive you to do things. to make you feel better. Would that be a way to describe it?
Yeah, but sometimes it's like I don't, like, do something that, like, other people can see. Like, sometimes it'll be like, "Oh, I feel like I hurt someone's feelings," like, I need to, like, think of 10 ways. Like, or if someone, like, makes me mad, I'll be like, "I shouldn't have felt mad at them. That's bad. I need to think of, like, 10 things I like about them." So, like, it's not always something people can see, but it's, like, things like that too that kind of just happen, like, in my mind. Like, I don't know if that sounds
And so,
crazy.
yeah, that makes sense. So sometimes it's an action, but sometimes it's another thought to counteract that initial thought, that initial
Yeah,
negative thought.
yeah.
Do you feel like these thoughts, like, are they helpful to you, or is it frustrating to have to go through these?
I feel like it depends. Like, I don't know when I'm, like, thinking and it's me and it's like something's wrong and I need to figure it out and it's like my brain's helping me, versus, like, my, like, friend didn't text me back for a couple hours or something, and it's like my brain's like, "Oh, here's all the ways things it could mean about how she, like, hates you or feels this way or this happened to her." So it's like it's hard for me to say because it feels like reality is, like, mixed in with it, and then it's like I mean, I feel like in some ways it helps me because it's like I don't miss details on things like school or, like, at work and my, like, job on the
Hmm.
weekends.
I see. If you get to a point where you're able to calm your mind, if ever, do you find that an anxious thought immediately replaces it, or a new worry is just going to pop in no matter what?
Yeah,
Hmm, I see. And sometimes when people are experiencing the emotions around worry, they can feel it in their body. Has that ever happened to you?
I feel like I'm, like, never breathing
Mm,
deeply. Like, I feel like I only ever breathe to, like, right here, and then someone will be like I'll be, like, at a yoga class, and they'll be like, "Oh, breathe into your belly," and it's like, "Oh, this" like, I've been breathing, like, almost every day, and then sometimes I get headaches kind of, like, in between my eyebrows when I'm, like, really stressed, and then, like, when I go through, when I go through a breakup, I, like, can't eat for, like, 4 days after it.
I see. This takes a big toll on you.
Yeah.
So I guess how I would picture it is you kind of have this almost like baseline level of worry that's constant, like this alarm bell. Does it ever reach this peak where it gets to the point where all you can do is just handle the anxiety or the worry, almost like an attack?
Mhm. I don't feel like it gets there, but I feel like there are some days where it feels like all I did that day was worry.
Mhm.
It doesn't feel like I get to a point where I'm, like, hyperventilating or, like, need to, like, sit down or pass out or anything or, like, feel like I'm gonna cry. It's more just like this there are some days where it feels like I'm just worrying about the same thing for hours. Even if I'm doing things, I'm, like, not really there mentally.
Mhm. I see. And I know this worry can be related to the death of others, how people might feel about you, how you may be doing on your test. So it seems like there's no specific theme to these things. It's just these
Fine.
unwanted thoughts. Okay.
Good job. That's really
Oh, thank
good.
you.
How did you feel about it?
Yeah, I felt pretty good. I was trying to just like follow the thought as best as I could. And so one thing that I was trying hard to do is like respond with reflections, and then it was kind of giving you the chance to either say no or yes and kind of clear away the rubble as to what's going on in your mind. So like at the beginning when you said like I feel like I'm always worrying, I tried this is something I've been trying to do more actually in clinic is I'll like just flip it to the opposite. Like you can't remember a time when you haven't been worrying.
Mhm.
And then that even if I'm totally wrong with that statement, it's which I probably am, it still gives both of us more information as to like where you are.
Yeah. No, I thought it was really good.
Oh, thank you. I I find it like it's like hard to ask them these questions about like saying like, "Do you have obsessions? Do you have
Yeah, I know.
compulsions?" Like it is really like it's a challenging interview in itself.
Yeah. And it's, like, also, like, one of the things is, like, do you have secrets you're really afraid someone's gonna find out but probably aren't that big of a deal? Like, how are actually, I have asked it that way, like, once I knew someone in therapy and I was like, "Here's how I'm gonna say it, and you have to tell me what the secret is." But do you sometimes feel like you have a secret that if people find out, for some reason the world's going to blow up, even though logically you don't think that's actually true. And the reason I ask it that way and why I paused you at the point you were at was because it was leading beautifully into what I do send to people or their parents, or go through with them in the second evaluation session, which is less for clinical necessarily diagnosis and is more for helping me understand the lay of the land of their OCD, which is the Yale Brown Obsession Compulsion Syndrome Symptoms Checklist scale thing.
The Y-BOCS.
The Y-BOCS, yeah.
The Y-BOCS!
Which I feel like can be super helpful for people just to understand, like, here's to broaden, like, everyone knows, like, oh, OCD isn't just, like, needing to have your bathroom be clean or something, like, but I think to actually give them, like, here are the things that they're so common, that they're in, these 100 things are so common in OCD that they have their own subcategory. And so we are going to take a very quick break. And then I want us to talk through some of the stuff on Y-BOCS because I think it can be really helpful to have some examples for people of all these different areas of what OCD can look like, including pure O or obsessional, or more like ruminative OCD subtype.
Pure O. I'm sorry, I've never heard that before.
Don't. We'll be right back after this break.
Okay.
So we're going to talk the Y-BOCS. So one of the things Preston was really good about asking was, or that you sort of asked and I kind of directed you in my answer as well, it was...
I'll take it. I'll take the credit.
You were asking about panic attacks, which is good to ask people with OCD because they can definitely get them. And the way I responded was purposely to help us talk about the Y-BOCS, which is hours per day on obsessions or compulsions that people spend. And so that's like one of the metrics that we're treating towards in OCD is not almost in any form of the treatment, which we'll talk about in a little bit. It is not aiming at getting OCD to be zero and cured, right? It's similar to other anxiety disorders, but I think especially with OCD, is helping people figure out the places it shows up and then helping them have a set of skills or ways of responding to their OCD voice or brain that sets them up to, more efficiently play whack-a-mole so they can like be chilling the rest of the time. Because as you were asking about, the OCD will move to different topics over a lifespan. Some people will have more than one, or stick with one for a long, long time. I think one of the underappreciated parts about OCD as well is like, when we'll talk about like medical PTSD. So like something happens in a hospital or illness and that thing gives them like trauma or flashbacks or like kind of hyper arousal. I wonder if one of the parts of OCD beyond the like kind of hyper aroused nervous system in general and like attention to anxiety related stimuli is like kids with OCD, the way they are responded to and the frustration that people can have with them or the fear people can have with not understanding what OCD is can kind of be like a secondary structure that can make it so that interacting with their OCD in a better way is even harder. Like they can get parents who are like freaking out every time they're freaking out, or doctors who are like, why doesn't my meds work on you? Or like misdiagnosing them as like something else. And so I just think there's a lot. We think we understand OCD, but I think there's so much to it that people don't understand that creates a kind of shame beyond just the OCD itself. So what all of that is to say, when we're treating OCD, we're looking at many, many areas. There's an initial screen about time spent performing compulsions. How much does like obsessive thoughts get in the way of your day-to-day life and function, distress, resistance, or trying to push back against? How much time do you spend trying to like not think about the pink elephant, to use that one example everyone uses? And then compulsive behaviors, how much they get in the way of your life, and then your sense of your degree of control or ability to respond to your compulsive behaviors. So that is the kind of scale screener. And then the thing I wanted to talk about was the symptom checklist. So, Preston, are you looking at it right now?
This is interesting. So I got this pulled up right here.
Yeah.
Like, I think you're right about how specific they are. So like even looking at here, miscellaneous obsessions, like an obsession with superstitious fears or or like a random color having a specific significance.
Mhm.
And then, yeah, obviously, like ritualized hand washing, which I think is like the classic one in the media.
Mhm.
But then, there's like excessive concern with environmental contaminants like asbestos and
Mhm.
radiation. Like it's that, like asbestos is that common that it gets a shout out on the Y-BOCS. And I imagine, it probably shifts culturally, but I'm
Yeah.
sure for a generation, and that's probably still lingering. Asbestos has been a lead character in their obsessions.
Yeah. I think, like, one of the things about this, if you look at them, is, like, there are there is a cultural component, not just to the specificity or the time of, like, these ones that we're talking about, but the way that if you think about what we're gonna talk about, which is, like, the exposure and response prevention treatment, then the treatment is often being like, "It's okay if this, urge or thought or intrusive thought or whatever is present, and we just, like, live with it, and it's okay." If you look at some of these, most of these are, like, threatening to your social belonging, and thus they cause shame, at least in the way we've thought about things for the last couple 100 years. So there's aggressive obsessions, right? So it's very unsettling for people with OCD to have a thought like one of the common ones, super common ones in postpartum anxiety is like, I'm tired and I was holding my baby and they were crying and I'm so tired that I thought about like the thought in my mind came of like I could just drop my baby. And people everyone, basically many people have that thought and they never do anything about it. But people with OCD have that thought of aggression and it's so disturbing to them and says to them they fear so much about who they are as like a mother or a parent that it gets stuck and then it becomes bigger because they're like, "Oh my gosh, did I really think that? Did I want to throw my baby? Am I a bad mother? Am I going to abuse my child?" Like that is how the OCD goes, but then you look at the others and it's like sexual obsessions, cleanliness is a place of shame for a lot of people. And so it's interesting how the culture interacts with what the OCD sticks onto.
So it's like the thought pops into their head
Mhm.
and it's an undesirable thought. You should drop your baby, or I could just drop my baby right now. And then
Mhm.
that person immediately almost says, like, if my mind created it, my brain brought forward this thought, then therefore it must be a part of me somehow. And somehow my
Exactly.
character is producing this. Okay, I see. And not everyone has, like, some people occasionally have those thoughts every now and then, maybe easier for them to push away. But if that thought's coming multiple times a minute for your entire life, that would be like exhausting, I guess, to say the
Yeah.
least.
Well, it's like not even the thought that's coming, it's the like response to the thought. Or what we talk about in like ACT is the Buddhist metaphor of like the thought would be the first arrow that is shot at you. And then all the rest of the pain is coming from the second through 100th arrows, which is in this example, the mom going throughout the rest of her day. And then when she's holding her baby, scanning her body of like, do I want to throw this baby? Is that thought going to come back? I'm such a bad, blah, 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 blah. And that's one example. But like, I mean, my OCD of choice, especially when I was younger, was scrupulosity, religious obsessions. What's up? Um, and that one was a fun existential one. So it can really be in any life area. But I think that some of these ones that are so common because they're things that were kind of like hush hush or they're very inner experiences. And so there's less opportunity for them to be like normalized.
I see. Yeah, and you would never want to share with someone that maybe had a sexual thought about a child or something
Right. Exactly.
to the point where it's, and that's so common that it's even like listed specifically on the Y-BOCS.
Yeah. Many people with OCD have some sort of fear of being like sexually wrong in some way, basically.
When I don't know how this qualifies, maybe I'm oversharing here. When I was at the academy, um, I would have these intrusive thoughts about being disrespectful to like the authority in the military.
Hmm.
So it like made me nervous and I like wouldn't want to interact with the brass, I guess.
Hmm.
So like for example, they'd be like, "Oh, this 3-star general is coming to sit at your cadet table at lunch." And like I would just continuously have this thought that like you should flip them off right now. Like
Hmm.
imagine how socially terrible that would be for you to just like degrade this person or like show extremities to the or like rip off profanities or something. So it was always interesting. Like I liked to do academic stuff, but I never wanted to venture into like the cadet leadership roles where I'd be hanging around generals or colonels a lot, because I would always have these like this thought would pop in my head that like you should you should do something that would be like the equivalent of a social suicide right now to this person.
Yeah, no, but like, right? And there was a level of it that even if you had a history of like not doing those things, the feeling of it being so strong, or like being like, this could happen and what if I can't control it? I think that also gets to like, I'm looking at the bottom, ones that say miscellaneous obsessions, and one of them is fear of saying things, certain things, fear of not saying just the right thing, fear of losing things, intrusive thoughts. And this brings us into our triad. Think about someone with ADHD coming into your office who has a diagnosis of ADHD since childhood,
Mm-hmm.
and they say those things. What do you do with that?
Yeah, I guess honestly, without seeing that specifically on the Y-BOCS now, I probably would have attributed it similarly to just fears that have been learned from their ADHD.
Yeah. Yeah. And like, is it OCD? Like, depending on how common it is, who knows? I think also if we zoom out to kind of a neurocircuitry approach, like anxiety is also an attentional difficulty. Like anxiety is a different part of the brain and a different kind of prefrontal disinhibition, disconnection, whatever. It's actually, well, I guess it's increasing the inhibition, but you know what I mean? It's like your attention and the ability to modulate your response to stimuli, both internally and externally, is kind of funky. Like the response is like not what we would call neurotypical. And whether there's like, environment
Yeah, it's
or
still
if
holding
it's
your attention
genetically linked.
captive.
Yeah. So, which I think is interesting in terms of that. It's like something similar, sort of, with like tics or Tourette's. Um, a couple other just ones for worth mentioning is that there is like a hoarding/collecting compulsion part of this. So, thinking about that when you're seeing people with OCD, of like asking about their home environment. Not that everyone with OCD has that. Some obviously people with OCD have very clean environments, but just knowing like when we think about function with OCD, asking about like self-care, hygiene in home, asking about school, work, and then asking about like how does it show up in like relationships or interpersonally? Because I think this can also be easy. There's cases that I think can be easy to mix up with like social anxiety components that might be more of like an OCD. Anything else you notice on here? Want to say?
Yeah. I guess one interesting thing I noticed, like looking at the hoarding and saving obsessions. So it says right here, distinguish from hobbies and concern with objects of monetary or sentimental value. And as you mentioned, like maybe someone with OCD has a very clean home, but they can also have like cluttered homes for different reasons. And so one thing I was talking about with an attending was about how, like differentiating between OCD and hoarding in patients. And one thing that's like fascinating, and I guess where you go is you ask the patient how they feel about the item that's in their house. So most hoarders or patients with a hoarding disorder will kind of feel like they like everything and they kind of want to hold on to it because like what if I might need it later, and like I don't want to get rid of this just yet. But the patient with OCD may say, like, I hate this clutter. I want to get rid of it. But because I'm so worried about throwing a bill out that I didn't pay, I have to recheck and check my mail 7 or 8 times in each envelope before I can throw it out. And that's so exhausting to me that I let the mail pile up. But now it's like mail has completely covered my entire like living room and my couches and stuff. And I hate it there and I want to get rid of it, but I can't because I have to go through these steps and it just feels like torture.
Right.
So you walk into the house, it looks the same at first, but then
Mhm.
then you just immediately just go to like how they feel about the objects. I just found that fascinating.
Yeah. It's like as a coping mechanism, you can end up with like such a similar picture on the outside, but how you get there is so different. Like, I mean, similar, like if you think about like substance use or eating disorders, it's like every story behind how that became the way of dealing with something is different. But so, Y-BOCS, I don't necessarily recommend people go and look at it and try and self-diagnose, but it is something that I think can be really helpful if you're like a primary care doctor listening to this and thinking about like your patients that are on that damn wait list for psychiatrists. That can be a helpful thing just to explore. And then I wanted to talk a little bit about treatments from the medication standpoint. So, Preston, you mentioned Paxil. Off the top of your head, what are the other things that you think are FDA approved for OCD in adults?
It's funny. I love and hate these questions because I'm like, oh yeah, a chance to show off my knowledge, but then like there's this like part of me that regresses to like getting pimped. So like
I mean,
my
I can
mind goes
go. I
blank.
feel like
No,
I
no, no.
thought you
I
would
want
like
to go.
asking that.
I'm just sharing. So I would say sertraline, fluoxetine, and clomipramine, I think, are
Mm-hmm.
coming to mind. So that one's
Yep.
the clomipramine being a TCA.
Mm-hmm.
I'm not sure if there's any other SSRIs off the top of my head that are approved, and I'm not sure if any of the SNRIs are approved.
Yeah. So we have Luvox, so fluvoxamine,
Hmm.
and then citalopram and escitalopram,
Oh.
Lexapro. And then for peds, basically it's all of those are approved. And then Paxil is one that's only for adults. I will say on the pediatric side, some of them are like age 10 plus, like clomipramine. I think clomipramine is later on. Some of them are age like 6 plus. So it kind of depends for that. But that's just the ones that are FDA approved. So I would say being FDA approved in psychiatry for an indication is not everything, but it's also not nothing. So I feel like sometimes people will kind of go rogue on like medication too. And I don't know that that's indicated unless you have like a really good reason. Do you know what I mean? Like I feel like sometimes we'll be like, oh, well, sertraline didn't work, so I'm going to like do
So,
Caplyta or
so
something. Like,
now whatever I feel like doing, yeah.
yeah. It's like, okay, maybe
Okay.
let's try another FDA approved agent while they're here waiting for us.
Yeah, everyone's partial to their own like agents within the realm of like an FDA approval treatment. Which ones do you like the most?
I mean, I think it depends. If I'm treating like reproductive age or like prenatal, pregnant, or postpartum and they're breastfeeding, I tend to go with sertraline just because it's one of the best studied ones.
Mm-hmm.
Um, if it's someone who is very, very scared of weight gain, then I'm avoiding Paxil, or has any cardiac conditions, I'm also avoiding Paxil. Um, if they are someone who forgets to take their medicine and has comorbid ADHD, I am thinking Prozac. And if they're someone who has any heart condition again as well, I would think away from citalopram in terms of QTC prolongation. Clomipramine I will use, and I feel like most of my attendings, like at the OCD Institute, they'll go to clomipramine probably faster than people who aren't being thoughtful and kind of going like they think more people should use clomipramine. It would probably be my like third line choice, but I would try like like some with like a little bit different specificity within like the SSRI and SNRI class. Wait, yeah. But so I feel like for me, it's like, let's say it's a person who's not pregnant, there's no contraindications. Usually I start with with fluoxetine or sertraline. If those don't work, then I go to Luvox. If that doesn't work, then I go to clomipramine. If that doesn't work, I circle the horses and I question if this is OCD and I'm not missing bipolar. And then I continue from there and I get, think about adjuncts, think about other things. You can think about interventional, like TMS was something that was common for the level of OCD we were at. But I think when you think about something like Lexapro, you need to go to high doses on these, and you can't really on citalopram and escitalopram because of the QTC issue. And then you don't want to have the conversation with an OCD patient of like, this might cause your heart to have a really dangerous rhythm. Like you can't avoid it. Because Lexapro, like the top dose is 20. Some people push to 25 or 30, but it's just, I tend to stay away from it unless you have someone who's like complex, like liver or kidney person who needs minimal interactions.
Mm-hmm. Whereas sertraline, you can crank them up to 200. Fluoxetine, you can up to 80. What's the max dose of Luvox you've had a patient on?
Oh, I don't know off the top of my head. I don't think I've got 80. That might be not right.
Mm-hmm. I think I underutilize fluvoxamine.
It's pretty decent. I mean,
it's a good episode.
There's always the case of like it's a newer-ish one. It's not super new anymore, but there's some thought that it's like slightly different from like a serotonergic norepinephrine profile, I think, that might make it sometimes more beneficial. And then I think clomipramine, like, right, like we're using a different mechanism can work differently. So it's just the thing I look out for in clomipramine is like, I don't put someone who is, I'm worried their suicidal ideation is not just intrusive suicidal thoughts, just in terms of like overdose risk and things like that. Those are the medications. I also think thinking about PRNs in OCD, if they have comorbid panic or just like knowing they have a safety blanket a little bit is helpful, especially when they're going through exposure and response prevention. So I tend to go with like, again, depending on comorbidities. In kids, I think like a clonidine can be useful. I think that hydroxyzine, is one we all use all the time. I tend to stay away from benzos because benzos can interfere with learning, which can interfere with the efficacy of like exposure and response prevention because you're not actually consolidating in the same way. But I'm not against them all together.
Yeah, like benzos are really good at anesthetizing the anxiety, but then make it hard to interact with anything else.
Yeah, well, I mean, there's been studies on like doing exposure and response and like some trauma work on benzos, and it like prevents like the learning. So basically, like your exposure work is just like, it's like not 100, right? It's never 100% one way or the other, but like we tend to avoid it because like, so this one in particular, like we also like when we do, which we will talk about in one moment on our Patreon section on exposure and response prevention, we tend to avoid as needed meds as much as possible when you're in an intensive OCD treatment setting because it's part of the issue is like the avoidance of the stimuli. So like using a med to avoid the stimuli is counterproductive when you're in the acute setting in particular.
Sure. That makes sense.
Any other meds you think about or things you think about when like looking at this list of medications for OCD?
I guess maybe propranolol is just a thought. Yeah. So, and I know it may not be the best PRN for chasing anxiety, but like maybe if your OCD is related to a specific scenario, like, calling someone or test anxiety, like you could offer it then. Like that could be an option.
Yeah, no, definitely. Especially also like there can be like comorbid performance anxiety in terms of that.
Probably stemming from their OCD. That makes sense.
Probably.
Yeah.
They're like, I'm going to be punished for this after that. By myself. Me is going to punish me. You can catch the next part of this on Patreon.
It's patreon.com/howtobepatientpod. Thank you all so much for listening. How's the show? We want to hear what you think. We want to hear your formed thoughts. We want to hear your intrusive thoughts. If it's a thought that we don't want to hear all your intrusive thoughts, and you don't need to feel compelled to tell us. But we do want to hear the thoughts that you want to share. And you can do that by reaching out to us at howtobepatientpod.com. We also have our How to Be Patient Instagram, or you can find me at It's Presro or Margaret at Bad Hour every day. You
can find us in the Spotify comments every Monday afternoon after releases of episodes.
Lurking in the Spotify comments. A special shout out to someone on Apple Podcasts who left a wonderful review. They said, I'm already a big fan of the podcast, but the recent episode on the history of lithium was just chef's kiss. More history episodes, please. So we'll happily incorporate more history and her story of the world. Thanks again for listening. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Margaret Duncan, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Portizo. Shout out to Jason. Thanks for letting us bring you on these wild goose chases. You're a great
We don't make it easy.
No, we don't. But Jason makes it look easy. And that's the important part. Our music is by Omer Benzvi. To learn more about our program disclaimer and ethics policy, submission verification and licensing terms, and our HIPAA release terms, go to howtobepatientpod.com or reach out to us at howtobepatient@human-content.com with any questions or concerns. How to Be Patient is a human content production. Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.